date stuck right there.
Yeah. All right, we are back. Senate Health and Welfare, and we are continuing testimony on S-197, which is the PFAS related bill. And we're hearing first from Jessica Barner. So Jessica.
Good morning. Thank you for having me. Jessa Barnard, the Executive Director of the Vermont Medical Society. We represent physicians and PAs across the state. And I will say in general, we certainly support the concepts in the bill of reducing PFAS exposure. But I'm primarily focusing my testimony on one section of the bill that we do have concerns with, and would respectfully ask your consideration to remove section 4, which is dealing with a PFAS registry. So the language of the registry asks that a healthcare provider who, I'll sort of condense a little bit, diagnoses a patient with adverse health conditions and diseases that may be attributable to PFAS exposure, report those individuals to the department no later than 6 months from the date of diagnosis. Our concern with that is the breadth of conditions that may be attributable to PFAS exposure. There's actually I included a link, and I encourage you to take a look at it, a really nicely done guide for clinicians on PFAS and health that was just published by the CDC Agency for Toxic Substances and Disease a couple weeks ago. And the guidance goes through and lists a range of health conditions that may be associated with PFAS exposure, while in some cases the evidence is limited or inconclusive, including things like increases in cholesterol, small decreases in birth weight, different sorts of cancers, pregnancy-induced hypertension and preeclampsia, ulcerative colitis. Because those conditions may be attributable to PFAS under the current language of the bill, that would require a healthcare provider to report patients diagnosed with all of those conditions to the registry, even if they have no history of PFAS exposure or any testing showing they have positive PFAS levels. So for example, about 34% of Vermont adults have high cholesterol. So about a third of all adults would need to be reported to the registry. And 1 in 13 babies are born but low birth weight. So again, it would require all of this reporting without any required link actually to PFAS exposure. Even if the registry was more focused on PFAS testing results, we also have a concern with that direction, since we know almost all adults, unfortunately, have positive PFAS levels. So at this point, given that from our understanding of the evidence, and while we hope the evidence keeps developing and we really need this evidence, there is limited clear linkages between PFAS exposure and what health conditions may develop at this time. So in fact, that guide goes on to give more detail about it. They actually recommend in some instances PFAS testing of patients, but it is for the intent of reducing sources of exposure. So, to identify is drinking water, is something in your neighborhood or workplace environment a concern, and not to, at this point, link it to a specific health condition you may have. And they have the warrant, they then sort of give some disclosures about PFAS testing, that the limitations are, it doesn't indicate whether a current illness can be attributable to PFAS exposure, and PFAS blood test results do not predict future health outcomes. So again, in summary, while PFAS clearly can be detrimental to health, at some level, that level is not yet accurately quantified, and more importantly, the amount of harm and the causation with illnesses, conditions, or cancers is still not fully developed. And while we support efforts to address the sources of PFAS exposure and contamination, at this point, we don't think there's enough clear evidence to require a registry, and that the registry would not be useful at this time, just because we don't have enough to know those linkages. So thank you for the opportunity to clarify our position.
Thank you.
The
number of conditions associated with PFAS is, as you said, huge.
Mm-hmm.
So is there any, as I thought about this section of the parts of the bill, may ask the question later after we've taken further testimony, but how to perhaps use some of the information from CDC that could inform physicians and make it available in some way, but we'll look at that as we go on.
Sure. Thank you.
Thank you. Okay.
Question, just one quick question. how do you determine exposure to PFAS as far as, the aftermath? Is it blood work or what?
My understanding is there is blood testing, yes, that can then determine if you have higher than expected.
Do our bodies retain it for a certain period of time?
Yes, a long period of time. And there are probably other experts testifying this morning that,
It accumulates.
Yeah.
Okay.
And one thing we could do would be to test, to have a registry for people who don't have PFAS.
That would be interesting. How do you not, right?
No,
Okay,
the testing that went on would be very expensive, and we don't want to add to the expense, but I bet that we couldn't find too many of them, even the ones that are newly born.
right.
So as representative of the medical society, is PFAS testing part of an annual physical? Is it part of the?
No, it's not at this point, sort of, I don't think standard of care to routinely do it. I think it's more at this point, if there is a sense of concern, like if you have had your well tested, for example, and the water is high. I mean, that, the guide kind of that just came out, guidance talks a little bit about that, not necessarily saying everybody should have it tested, but if you might have some concern based on workplace exposure or, environmental sources that you're frequently in contact with. And that may change over time. I mean, again, I guess that's in our sense why a registry is a little premature right now, is the evidence is still really changing and under development. But if we had, in the future, clear linkages of, yes, if you have this level of PFAS, you may be at risk of that. But right now, again, it's more to identify if you may be getting even more than the general background population exposure, but a concern for you based on your work or housing.
One more question, probably not for you, but maybe for the committee. I know the state has a very robust radon testing system. Is there, and I think I may have heard earlier in the year earlier last month, PFAS testing for raw waters. Is there a similar program?
A&R is doing that. That would be a Matt Chapman. One of the people to ask is Matt Chapman. So we want to get that.
I think you mentioned that in the education.
He did. Yeah.
What do you mean the ag?
Ag.
The day we were at ag?
Correct. I think Matt mentioned it when he was here. Could have been mentioned. Thank you.
Thank you.
So are both of our Department of Health folks on Zoom? Thank you. So we have Sarah Owens and Jesse Hammond here. Do you want to coordinate your comments?
Sure. Good morning. I can go first if you'd like.
Please, that would be great for the record.
My name is Sarah Owen. I'm the state toxicologist with the health department in Vermont. So I was in last week and provided some testimony regarding a couple of different sections of the bill. I was asked to come back to talk a bit more about the health effects. I will address a couple of things that came up in the last few minutes. You are right that most people in the U.S. have PFAS in our blood. PFAS can be transferred from the pregnant person to the developing baby, so there is significant placenta transfer. So even newborns will have some body burden of PFAS, and that's been demonstrated by quite an extensive blood monitoring program that's run by the CDC. I was asked to talk a bit more about health effects and the expected time frame for health effects. As you've heard this morning, PFAS can be associated with quite a large number of health effects, including some things that are not very specific to PFAS. And in fact, the ATSDR clinician guidance that was just mentioned does state that PFAS toxicity is not associated with characteristic signs or symptoms. So some of the health outcomes that you've heard about, things like higher cholesterol, decreased immune response to antibodies, these are things that could be expected in the shorter term. So maybe, a year or less of exposure. We also know that PFAS can affect the developing baby. By definition, pregnancy is a short-term arrangement. So you're not pregnant for
Speak
more
for
than a
yourself.
year.
Sorry.
It's okay. So by definition, a health outcome that affects a developing baby is a shorter term health outcome. PFAS can also increase our risk of cancer. That's kidney and testicular cancers. That would be a longer term health outcome because we know that cancer can take some years to develop. But in general, all of the other health effects that are possible with PFAS exposure can be considered on the shorter duration. I'm happy to talk more, or I'm also happy to take questions if that's helpful.
Thank you. So we'll see if there are questions, and then we'll move on to Jesse, and then if you'll stay with us for a minute, we might have some other type of questions. Questions? Good. So will you send us again maybe a summary of the health consequences so we can?
Yes.
Jesse, and Jesse Hammond is here, so why don't you help us?
Sure, I'm Jesse Hammond with the Division of Health Statistics and Informatics at the Health Department. I also was here last week and was asked to come back and just add a little bit further comment related to the language around registry. As I stated last week, it would be a very significant lift to create such a registry. As you talked about earlier this morning, there would be a very significant volume of people that would have to be counted or included. And given that most of the health effects are very non-specific, I don't believe at this time we would be able to develop a registry that would have meaningful value for analysis and understanding what the bill wants to capture and look at.
Thank you. Yeah, and so your testimony is very helpful. I do have a question for both you and Sarah. It's probably a question that others in the department can answer, but the section on reporting and registry seems to be very complicated and very costly and perhaps not valuable just because of the ubiquitous nature of PFAS and the comprehensive healthcare causes, things that it affects. So my question is this: might it be more helpful to have language that would, in one case, direct the Department of Health to develop PSAs regarding PFAS and where PFAS might be found? For example, suggesting that consumers check labels, but some kind of a PSA program or public service announcement, something, or educational piece for the public. That's one question for the department. The other question is in sharing information with our provider community, such as the CDC information that Jessa Barnard mentioned from Vermont Medical Society, that information gets out to providers. Not that they're going to be able to, I don't know how they can limit people's exposure, but at least to have an awareness of some of these concerns. I think many of them already are, particularly if you live in North Bennington. But so those are two questions that I have, one on the provider side and then one on the public information side. Is that something you can speak to from the Department of Health perspective?
Yeah, I can answer some of those. So from the provider perspective, that is a great resource. ATSDR did update that provider guidance, the clinical guidance, just maybe 2 or 3 weeks ago. So I think that the department has some means that we can make sure that gets out to the right audience so that healthcare providers can have that as a resource. We do have a lot of information on our website. So speaking more to the public side of things, we have some information about the health effects, how people can be exposed. But I think we could add to that website to help the public understand more about the well testing program that DEC has done. Also, as the US EPA is moving towards regulating at least 2 PFAS in drinking water, potentially more, we can make sure to provide that information on our website when EPA makes that information final.
Okay, that would be helpful. So it's more of a web page. What about the idea of a public service announcement encouraging the Department of Health to provide some a direct link for the public to the web page? Is there anything that would be useful there from your perspective?
Yeah, I think we could take that back to some of our folks and have a conversation about what that outreach might look like.
Okay, all right. So we are working on the bill, and it would be good to get some of this information and language into the bill, probably in place of what's currently there in terms of the registry and the provider collection of data. Maybe we're going to put a prize in for the one patient who doesn't have PFAS in his or her blood.
We'll give them a pie.
We're going to give them okay. So, okay. Thank you. This is really very helpful. The other question I have for you, Sarah, is Dr. Owen, is on the definition that we currently have in the bill on PFAS. Did you look at that at all? Can you comment on that?
It is a very common definition, and it's unfortunately a very broad definition. And you may have heard some of this in other committees, but the definition really focuses on the carbon-fluorine bond, which is a characteristic of PFAS, but it is not the singular defining characteristic of PFAS. You know, we think of PFAS as having very high mobility, very long half-lives, and being very toxic at low levels. The presence of a CF bond does not always impart those properties. So we know that common antidepressants, blood pressure medicines contain a CF bond and could be defined as PFAS.
So, so we have heard that it was an overly comprehensive definition. But your input is helpful. If you have suggestions that you can make on that definition, that would help us going forward. We also heard from Matt Chapman, who made similar comments. And so we'll perhaps get the two scientists together. Actually, one's a lawyer, one's a scientist. Put you guys together, that would be great. If we could get some improvements there.
Yes.
Any other questions for Department of Health? Okay, good. Thank you. I think what we'll do is we're going to go through the bill one more time with Katie. And maybe as we look at those problematic sections, we might ask you to work with others, Katie. Yes. And that's why you're pulling that up, and I will share with the committee that the Senate Agriculture Committee is working on the bill, on their sections of the bill, and I will be meeting with Senator Starr just to understand where they are and what our timing is for coming together with our recommendations for the bill and their recommendations for the bill, so that we can have our proposals go to this full Senate in together. It's good. It's exciting.
So there's no updates to this, the original bill?
We haven't made any
Okay.
amendments. It's just the bill is introduced. Yep. Katie McGlynn, Office of Legislative Counsel. So you want me to just sort of walk through the bill again?
Yes, please. And
Okay.
we can stop along the way and
Okay.
do what we need to do.
Sure. So the first several sections are, the language is very similar in that it's about prohibiting the procurement of products that contain a regulated PFAS. Regulated PFAS is defined in the definition section. So section 1 prohibits a school district from procuring the product. And then in section 2, we lead with the definition section, but then this pertains to state procurement of products containing PFAS. The state shall not procure a product, including carpets and furniture, to which PFAS has been intentionally added in any amount. And then the third section that is has the same language as the other two sections, pertains to municipalities. So municipality shall not procure a product, including carpets and furniture, to which PFAS has been intentionally added in any amount. And the conversation that you've been hearing from witnesses is the challenges posed by putting the onus on the consumer of knowing that a product that they're purchasing contains PFAS.
So we'll have to have, did ask for Jennifer Fitch. We have to get buildings and grounds in here and buildings and grounds, BGS, and we'll have to get, we'll have some folks in to testify, and that's what we may have to just flip what we're doing, including having, so we'll clarify this section.
Okay.
Yeah, I think it would be really hard on all of them to know. And then if they purchase it, what do they do if they find out later?
Right.
Do we have a list of items like construction material that the state is testing? I'm thinking about vinyl siding, which is being used to cover up clapboards that might have lead paint on them. So,
The lesser of two evils,
Right.
which is worse.
yeah, just wondering.
This is a question that, we can ask. I do know that there are some folks representing consumer products or chemicals who want to testify. One is the auto industry, the other is Honeywell, which produces a PFAS substitute, which is conceivably less toxic. And we're gonna all have both of them in. And your question is a good one, so I'll follow up on that. Any suggestions you have for testimony to answer some of the difficult questions we have in front of us would be helpful. We'll have to ask, I think the AG is in here somewhere as well.
Any intention of inviting in like the NEA or the Association of Superintendents to react to the comment about procurement of?
Yeah, I think the first step for us is to make it not dependent on the consumer finding out. So I think we do need to do that. And before we take testimony to tell us that this doesn't work, let's try and put something forward that is a little more helpful. And then we'll get testimony. Otherwise, we'll have a
Yeah, I just want to piggyback on what Senator Weeks said. It just, every time we had another set of guidelines and more guidance for school districts, we have to understand that their capacity is not there to deal with it. So we're going to be adding another layer potentially of capacity. And we've seen it with the PCB testing, and I'm sure it would probably be similar with this.
Yeah. The question is, how can we have manufacturers certify that the product is PFAS free and do it in a way that we've done for other products? So I'm thinking that might be the language we need to co-opt from other sections of statute. Katie, maybe we could do that.
Yeah.
And then we would have to define the product type.
Yes. And I mean, that's sort of similar to the approach you've been taking so far in PFAS, that looking at product type.
Yes.
And, banning the manufacture and sale in the state. and having the certificate of compliance that the AG's office can request.
Something like that, or whether it's banning for sale or whether it's only notification. Those are the things we don't know because PFAS is ubiquitous, it is being utilized, and how do we ban something that for which there's no substitute? There may be products like that, but.
Yeah, there's a bill on the House side that has a ban on products containing PFAS. And there's also language there that creates a carve out. So if it's a product for which there's no substitute, as determined by the health department, then it would still be available. The manufacturer could still sell it in the state. So that might be
That's a place to start.
to look at.
We're good. I don't know.
Yeah, I'd much rather put the onus on the manufacturers
too.
than
Hello.
the purchasers.
Yes.
Small school districts and municipalities and the state for that matter. I just don't know how they would know.
Yeah.
S25 is already in play too from last year,
Yes, it
and
is.
it's with the human services and health.
Yes, it is. And they are looking at it. And they are thinking about putting other things on it. And we'll see what comes over.
I have a broad question that I don't know if you can answer, but can you even manufacture plastic without PFAS?
Yeah.
You
Oh,
can?
yeah.
Okay.
Right. You can manufacture plastics without BPA, without PFAS, without phthalates, without petroleum-based products. You can have, you
Is it
can
a
make
lot
it
more
from bamboo.
Is it a lot more expensive, I assume?
Well, the manufacturers might indicate that. But you don't have to drill for oil for some things. This is all petroleum-based product we're talking about.
Yeah, no, I know, and we were in the ag committee that day, we were told that that the PFAS adds a certain viscosity to the material so
It
that
does.
it can mold, and I was just wondering if there's a
Well, those are the
substitute for that.
fungicides that are added, and then they use the PFAS as a vehicle.
Right.
Yeah.
Right.
There's a lot there. Okay, so Katie, so let's go through, and then we've had a good discussion here. So maybe as we go through, we can identify how we might like to see some language improvements.
Sure.
And then go from there.
Do you want any changes to this first part of the bill?
Well, the definition. needs
Right,
help.
I've heard the conversation on the definition. I would just be aware that, I'm nearly certain that this is the definition that we've used elsewhere in statute, so,
Okay,
not to say that it couldn't be changed, but you might just wanna be aware if you're defining PFAS as one thing in one place and differently somewhere else, what the impact of that would be.
so unless there's a disagreement, we want to be consistent.
I am not, articulating that you need to keep it as is. You might want to look overall at whether a consistent definition makes sense. Okay, so at this point, I'm not hearing that I would bring back language to replace this yet. Okay, so section 4 is the Registry of Adverse Health Outcomes. This is based on the ALS registry, so it's similar. The commissioner is the commissioner shall establish.
10,000 foot on this one.
Okay,
Yeah.
so the idea is that the Department of Health establishes a registry, maintains a registry, and providers submit data to the registry. And that the health department would have an opportunity to study the correlation between the outcomes on human health and exposure to PFAS. Heard quite a bit of testimony on this piece. I don't know if you want me to pause here.
Well, I think our conversation, unless I hear differently, I think the conversation is to direct the Department of Health to provide public information and to communicate public information by way of their webpage and also public service announcements regarding PFAS and consumer products. Maybe it's something about how to look at labels, I don't, you know, we have to leave it to them a little bit. Can we think about that, would that
Sounds good.
be okay?
Mhm.
We did hear they can do it, that's nice.
Okay. Do you have any more specifics about what might be part of that, or do you want it part of the PSAs, or do you rather leave the language broader?
I think input from the Department of Health here would be useful, maybe Sarah can help inform that. But I do think having, identifying labeling of consumer products, letting people know out there, or concerns about any water testing that's happened. So there's a pretty broad look. If you live in an area where wells have been tested and PFAS is available, if you're buying new furniture or whatever, I don't know how to structure it for the Department of Health. There's a whole host of things that are consumer products that might offer exposure. We cannot, I don't think we're directing labels to be placed on all these things, but a lot of the products people buy are, say, PFAS free, and it might even actually encourage people to ask the question, does this stuff have PFAS in it? So some kind of communication with the public on that. And then have identifiable, a webpage link or a place that people can go at the Department of Health to look at the health consequences of PFAS and why it's a concern. So that's just all public type information. Does that make sense, or?
I think Department of Health doesn't get into product labeling at all. I mean, I don't, in terms of like.
They can tell people to look or ask. It's not, we're not asking the Department of Health to label products. We're just saying to the public through a public service announcement, this is the web page, this is where there's information about PFAS and your health. This is information about water contamination in the state. Not that we want to highlight that, market that, but, and then also whether suggesting that people look at product labeling to determine what they're buying is PFAS free. Something like that.
Okay. Okay.
All right.
Yep.
Does anybody have language or suggestions on that one? Or do you want, can we look at it? We can also decide we hate it. That's okay.
I will bring you back something to hate.
All right. Something to love. No,
Or
we
love,
want something
or
to
love.
love. Okay.
I have an example, you know,
I love that you looked at me, Katie.
when I bought a new car, I bought a car. And the dealership offers a treatment that they put on your vehicle, seats.
Oh, yeah.
And I asked the question, does it contain PFAS, S25?
Yeah.
And they said, we don't know, we'll have to get back to you. It came back, yes, it does. So something they spray out, it's
Yes, they do.
coated.
And the auto industry wants to come in here and testify for an exemption.
Okay,
Yeah.
so if you're in your vehicle for a whole day, and you've had that treatment done,
You're not gonna be tested negative.
Hmm?
Your blood is gonna have PFAS.
well, among other things. My blood. Okay.
So that's then there's the where are we on?
Okay.
What are we on?
We're moving past the registry.
Okay, and then the duty of health.
And then we have the drinking water public health advisory.
Okay.
You received testimony on this as well. That the Department of Health.
We didn't do the duty of healthcare providers? That's in section 4.
To report to the registry?
Yeah. Can we back up to that one briefly and suggest that maybe Department of Health communicate the CDC information, PFAS information? I don't know, VMS, what do you think about something like that? somehow communicating through the Department of Health or,
Jessica Barnard from Mount Pleasant Society, I know we actually have already sent that out to our members, but I'm sure that I don't want to speak to the department, but I think just having a link to those materials, if they're willing to put that on their website, would be good enough.
a link to the, okay, let's put that down on the webpage.
So instead of communicating directly, providing a link.
I'm
the provider
gonna look to, Jessica.
Either way, I think a link on their website would be sufficient.
A link to what?
The Department of Health webpage, with information from the CDC regarding the health consequences of PFAS exposure for the provider. All right, let's keep it webpage, and we might wanna, if we wanna expand it, we can do that.
Okay. Okay.
All right.
So then we have the drinking water public health advisory. Private and public drinking water sources contain PFAS. The US EPA has determined that PFAS may affect human development, immune and cardiovascular systems and may cause cancer. I think the testimony you heard was that this first sentence reads as a shall, or it does, like in the affirmative, private and public drinking water does contain PFAS. The testimony you heard is that not in all cases, based on the health department testing.
It's a bit inflammatory.
Yeah,
And
exactly.
Yeah.
it leads to shock. It would be better if you led people towards test results, not just leave them hanging with another threat of their mortality.
Agreed.
I know.
I also think this could lead a lot of people to get worried and paranoid and start buying water, and I just
PET
I
and
just
having to recycle.
I just am
Yeah.
not comfortable
I
with
did
this.
look online, the test kits are acknowledged by the environmental, whatever, no, I'm talking the state.
DEC.
Oh,
DEC.
DEC, yeah,
But they're $100 a pop.
yeah, they are. So let's kind of modify this language a little bit. How do you want to do that, Senator Weiss? How would you modify it? I mean, think about how to modify.
Will lead to, I think we should lead people to test results, lead them to science, not threats.
Fear.
Fear, yeah, exactly.
Oh, yeah.
Lead them to science, not to fear, yeah.
That
But
would be interesting.
I'm just not sure what the sort of general goal of the bill is. I mean, because it seems, I mean, not setting aside the pesticide part of it, is it just mostly about public information? I'm wondering if there's just a better way, just sort of do,
Consolidate it.
yeah,
Yeah, why don't we look and see what we get, and then we may just do that, because I'm looking at this and thinking, this goes up with the PSA, Department of Health webpage, and it all falls together.
and I think there's already requirements for making the water testing information public. I mean, our
Water testing, but not, but not the other stuff that we've been talking about.
yeah, but to
Yeah.
the last thing we just mentioned.
But we do not want to scare people. They're already petrified enough about whatever they, even dates.
No PFAS.
No PFAS? Okay, check.
Okay, and then we've moved on to the pesticide sections.
Okay.
And I believe I'll be send an ag looking at that.
That it?
That's it.
Good. Okay, good.
And your effective dates.
So many of the suggestions that we have here came from a group of citizens who are very concerned about PFAS exposure and asked to have a registry looked at and other things looked at. And so I think this is a helpful process to go through for them. Okay. All right. Anything else on this bill? So Katie, I think we've heard the committee would like to send love, not hate, and then, maybe some consolidation here of language. We do want to make sure that there's information available for providers. We do want to make sure there's information available for test results, linkages. And, I like the PSA concept. It may end up being something that is broader than PFAS, but we'll hold PFAS for now. All right, so we can think about this. And I'm glad to chat with you, and Senator Weeks will chat with you, this idea. Okay. All right. So we're gonna move on, but I know the people in the room want to make a comment, so why don't you, your name for the record and.
Thank you, Madam Chair.
Sure.
My name is John Brabant, and I'm here, I work for Vermont for Clean Environment. I just wanted to suggest, I agree that some of that language is problematic, but maybe a different approach might be to direct the Department of Health to adopt as a drinking water standard, at minimum, a drinking water standard that is equivalent to the EPA advisory, what is a healthful level of PFAS in drinking water. Currently, it's 0.004 parts per trillion. The Vermont State Health Drinking Water Standard, MCL, for PFAS is 20 ppt. So it's 6 orders of magnitude higher than what EPA is advising is healthy in drinking water. And having said that, it should also be noted that EPA has also said there are no safe levels of PFAS in the environment or in food or that can be ingested. So 0.004, that's the current EPA advisory. It's not been promulgated into a rule, but if Vermont were to follow that guidance and make that a Vermont drinking water standard, then they could post that on their website as FYI, this is the drinking water standard, and that would be good information for them to have, and grounded in science.
No, and we did hear this, when we were visiting with Ag, and I know it's an issue ongoing. So perhaps we can think about some language that would ask the Department of Health to evaluate the standard as it currently exists as compared with the EPA. Katie, can we do that? Or just put some language in asking Department of Health to help us with that. This is a whole nother big area of discussion. We'll think about it. And I thank you for reminding us, because we did hear that when we were in Ag. Okay, good. All right, so we'll keep working on this one, and it's a short bill, but it has complications, and we want to make sure we get it right.
Can I make a quick shout out to all of our wonderful students who are roaming around the building today?
Yes. Do you want to introduce yourself?
Sure, I'm Kennedy Desvel. I'm here with HOSA. It's Health Occupation Students of America, and we're just a program involved in getting early healthcare experience. So yeah, I'm really happy to be here today.
Where are you from?
I'm from Champlain Valley Union, and I do dual enrollment at Burlington Technical Center.
Awesome. Yeah. That's wonderful. Well, we're really glad that you're here.
Thank you.
I'm glad that you're at Champlain Valley Union.
And I'm glad that you're at Burlington Tech.
I try my best.
So what are you interested in studying?
Next year I'm a senior, so next year I'm going, neuroscience is my major, and I'm going pre-med.
Excellent. Really great.
Yeah.
That's
sorry to interrupt you.
You're not.
No, we're pleased that you're here. Thank you. Thank you, Senator Bullock. All right, so we're gonna move on to, and I'll talk with Katie, and if you have suggestions to make on 197, make sure you talk with Katie. Great. Let's move on to, I don't remember the bill.
Doula?
Yeah. And just so you know, Amy Johnson did send in some testimony regarding cost savings in doula services, which Kiki has posted on our webpage.
Great.
I think, now, do you want to testify first? How do we want to do this? Where's Jen? Do you have something further from yesterday?
Kiki has it, and she can post it.
All right, let's do that first.
For the records, Noel Langwell, the Joint Fiscal Office. I have finally got a fiscal note. It's a little, I don't usually do this, where I do a fiscal note before it's voted out. Because then there's no link to the bill, because this isn't posted yet, or it wasn't posted when I did it. So this is like a draft, and then when you pass it out, I will change it up so it says as recommended by Senate, and there'll be a link. So this is more of like a pre-draft draft, but the words will stay the same. The title will change. So I don't know if there's more questions from yesterday, but it pretty much says everything that I said yesterday. I mean, I can run.
It's not posted?
It should be posted now.
I don't see it.
Maybe refresh, because I think I told Kiki to wait till I got it posted, in case there was like a last minute.
Just in time fiscal reporting.
Refresh.
I did, there's
I
no
did, it's
Nolan
not posted.
Longmire.
Kiki, did you
Not
post
coming
Nolan's
up.
thing?
Sometimes, like, if you close it,
On the
reopen
bottom, I
it.
don't have it. Let's refresh
Yeah,
again.
sometimes the refresh isn't quick. It's under Mr. Nolan. Kidding.
Dr. Noel?
Dr. Nolan.
Can we just show
I got it. It's
I got
there.
it, yep.
Okay, good. Dr. Nolan, there he is. It's on
Are we gonna put it up on the screen or?
I don't think, I mean,
No?
it wasn't.
Okay.
Go
So-
ahead, Nolan.
So, yeah, there's nothing new in here. I talk about the multiple pieces. Here's the cost, the short-term cost. Actually, if you're looking at the fiscal note, just go to the fiscal impact, the last paragraph. And in fiscal year 25, there will be a cost to OPR for the Sunrise Review. There's no appropriation to the bill. We had the conversation yesterday that it might be in a bigger OPR bill, but there's money that would need to help them do this and other stuff. Fiscal year 26, down the road, it could range between 27,000 and 108,000. That's the state dollar. If you go to on page 2, you'll see a chart that I have high-low. There were 3%, 6%, 1,000, 1,500, 2,000. So that's the, either of those ends. That's the state share, not the gross. But that's coming out from the state budget standpoint. And then there would be some cost to OPR again, this time for staffing and all the costs that go into setting up a new profession, IT costs, etc.
Is that the cost estimate about the OPR bill? What's that?
25,000
Total, year to year?
No, I think once it goes, so that's the setup, that's the staff time for creating whatever it is they have to do. And then there are costs. I would defer that to Lauren Lyman, but that, in theory, when they set up a new profession, they set up a fee. And in theory, the fees help pay for the professions. So I don't know what the ongoing cost would be, but I think that would go.
Well, so, and actually, there's no cost, except to that person, OPR. There's really no cost for the doulas until another bill is passed with certification. I'm looking at Jen, she's shaking her head. Lauren, did you want to comment?
No.
Okay, thank you. Jen, did you want to comment on that, just where we are with Nolan?
Yeah, sure,
This is
it has
great.
to.
Thank you for putting this together.
Yeah.
As you know, I'm a little hesitant about the 6% utilization factor.
Yeah.
Can you expand on that?
Sure.
Based on
So I based that off of research, and all the research sort of refers to one particular study that said they had not seen doulas surpass 6%. I think in the short term, it's going to be lower as more providers start to come on to the program, get their Medicaid certification in the first couple of years. So I think in the first 3 to 5 years, it's going to be on the low end. And then what will help it get to higher percentages will be the amount of awareness and outreach that DEMA puts into it, whatever their Medicaid reimbursement rate is. So I know that you feel it could be up to 30 to 50%. And
I just think 6 is dramatically low. And I'm not talking about year one and year two, I'm talking about,
Well, down the road, I think if we're successful, it would be higher. I think that's the hope. But then at that point, I couldn't tell you what it's going to be. I can only estimate what I think it will be in the first couple of years. It's like with any program, you know, costs will go up, they'll go down. This is one of those programs we hope down the road, yeah, it could potentially cost on the higher end to the extent that it is successful. I think that would be the hope. But we don't know until we see how it's rolled out and what level of, you know, advertising and that DEVA and the professions do and sort of getting the word out. And again, like what the reimbursement rate is and how easy it is for a provider to become a Medicaid provider, to the extent that more and more of them become providers and so billing systems that may not exist within their small practices. So there's a lot of variables that would exist. I would hope that it is higher, you know, if the program is successful. But in the short term, I can only tell you what I think it will be in the short term. I couldn't tell you the long term. So I hear your question. I don't really have a much better answer past the 3 to 5 year.
So then that's the cost side. Then there's also the savings side that you can't comment on because we don't know. But I will direct folks to Amy Johnson's testimony. And the bullets that she has listed first are fairly instructive about reducing costs associated with perinatal mental health disorders, long-term health savings, connected improvements in child development, decreasing maternal mortality rates, improving birth outcomes, and so on. But then what's really neat is there's an article or a link here to Mathematica from May 2023, not that far behind us, specific impact of untreated perinatal mental health disorders in Vermont. So Vermont specific data that we may see some benefit from having the program in place. So she has a whole lot of links here regarding cost benefit analysis and so on. So we probably can.
if I may, I want to just again express a hesitation. So in industry, whatever the industry is, we're always looking at the return on investment. If there was a return on investment, which is as positive as her testimony indicates, which I'll accept that she's postulated that, industry, the insurance companies, will look at the return on investment as Blue Cross has done with their pilot, to look to see if there's a positive net return on investment. And if there was, they would go after it in a heartbeat because that increases their profit margin. You know, in this case, all we have is one pilot. So the case for return on investment, I think industry, again, if they saw that, they would see the benefit. They would jump on it faster than we jumped on this for Medicaid.
And I will share with you my interest in the profession industry of doula, which is demonstrating to us significant support and savings for mental health and health overall for women and children. So the money you save by investing in people are probably equally or more so important than making $1 on
the logic
insurance. Yeah.
We're catching up to it, right?
We are catching up.
It's still a relatively new niche, I would say. Well, new and old at the same
So
time.
why should Medicare be?
So can I just throw out one data point that I just looked up? A cesarean birth costs approximately on average $26,280. A vaginal delivery is $14,768. So you're looking right there at more than $11,000 for one birth of savings. So if a doula does that, and we know they do the math. It speaks for itself.
So the math, I don't want to interrupt.
I'm done, thanks.
Okay. Senator Hardy?
I'm a little confused by your concerns because we've had a lot of testimony and there are a lot of national studies that show exactly what Senator Kulik was just testifying, is that doula care saves money, it saves lives, and it produces healthier babies and moms. So all of that is to the good. Any industry, to use your argument, which any industry would jump on that, seeing the evidence. I think Blue Cross Blue Shield is trying to look within their own population specifically. I would be shocked if they don't come out and say, we want to do this immediately.
Well, they are supportive of the bill. So
they're supportive of moving forward. And I think that there's enough national data that shows the cost savings. And, I know that JFO has this general policy that they don't do these sort of larger cost savings in their fiscal notes. I think they should, but no offense, Nolan, it's not your policy. I think they should be considered in the fiscal notes because there is clear evidence that there is a cost savings to this. I hear your concern about the 6%. I think that's low too. And I actually think that it will be higher and more people will actually save more money because more people will take advantage of it. Especially because Medicaid tends to provide health coverage for some of the most vulnerable pregnant individuals, and therefore the savings would be even higher because they tend to have more health complications. So I'm not sure that I don't understand your argument actually, because I think there's a lot of national data that shows the savings.
Yeah, I will say Medicaid savings, and also when you think about equity, put equity into it, and taking care of folks from other cultures. We now have a huge number, at least in some of our districts, that the savings will accrue over time. And
can I just say too, the utilization rate, again, I'm on the low end because I'm just going by what other the 5-state experience. So utilization was low and they listed why. And that's the reason I'm going low, because I haven't seen anything that says it's going to be high in the short term. So that's why I'm on the low end, because there's plenty of stuff that tell me it's on the low end, not enough tells me on the high end. But they explain why I think it's on why it's on the low end. So to the extent that the DVHA's policies are different than what was in other states, it could be higher. But that's why I'm low.
okay,
That's all.
so, and it's a policy choice ultimately, based on the testimony that we've heard, and so we'll just, to answer your question, why Medicaid goes first, well, we want to see savings for the state. We're trying to save money, and that's what this will do. It's like, it's like any business, you have to put some upfront investment in to get the return later on, so that's what we're doing.
Well, I don't want to add that now at this point, but I might say one thing this committee can do in a couple of years is ask DVHA to provide some analysis. What's happened? What's the trends that they've seen in doulas? What trends have they seen in the other, prenatal, whatever, and see if there's any kind of evidence that proves. But unfortunately, we won't know until we know.
Okay. So what I'm going to suggest is we look at the bill with Jen, and then one last time, hopefully. Thank you, Nolan. A lot of work.
Langwell.
Dr. Nolan,
Good morning, Jennifer Carvey, Office of Legislative Counsel. So I do have a new draft for you. I've highlighted the changes in the previous draft. So this would add in section 1, the existing language that we looked at yesterday required DVHA to provide reimbursement to a qualified doula for providing services to an individual covered by Medicaid during pregnancy, labor and delivery, and postpartum period. And it was pointed out yesterday after the committee that that in some cases the pregnancy does not result in a live birth, and so it would be perhaps appropriate to say regardless of the outcome of the pregnancy, because the doulas provide support in the event of pregnancy loss as well. So that's why it says regardless of the outcome of the pregnancy, Section 2 is your legislative intent language that you talked about yesterday. It is the intent of the General Assembly that the Department of Vermont Health Access reimburse qualified doulas in amounts that are reasonable and adequate for the services provided and that are consistent with the reimbursement rates set by other states' Medicaid programs. And finally, I added language in the effective date section saying that Section 1, the Medicaid coverage would take effect on July 1st, 2025, or, and then it says, if a state plan amendment is necessary upon approval of the state plan amendment, whichever is later. So if there is not a state plan amendment necessary, it doesn't permanently delay implementation.
Okay, any comments, questions for the bill? How are you doing, Senator Brewer?
Yeah, I'm good.
Well,
Thank you. Sorry, I just want to make sure I was doing my due diligence as clerk of the committee.
and is there a motion on the table or you not?
I will make a motion to pass S 109
As amended.
as amended on this day, February 7th, 2024. Do I have a second?
Yeah, we can have a second. Is there a second? I'll second it. I don't usually do it, but I will.
Okay, thank you. Okay, so point of order. Do we have to vote once on the bill as recommended and then another time on the amendments and
No,
other
it's the
changes?
bill as amended, so
Okay.
it's all in one little.
That's what I thought. Okay, great. So I haven't done this in a while. You're the last person that I call on, correct?
Yes.
Okay, so I'll start with Senator Hardy.
Yes.
Senator Williams.
No.
Senator Gulick is a yes. Senator Weeks.
No.
Senator Chair Lyons.
Yes.
Great. So the bill passes 3-2 out of committee.
Terrific. So
3-2-0.
this is the first bill that we've done, and I'm looking at you because this is a pretty neat thing to be here for that, and especially this bill probably carries an interest for you. Great. So we need a reporter for the bill as amended.
I can report.
Good. You're on.
And I will be doing, when will this first reading?
So
will be-
you'll take it up. You need to get the clean copy
Mhm.
from Kiki.
That's sent her right now.
Right there. And then you take it upstairs, put the vote on it. Leave it there, get a copy for yourself. Will go on notice tomorrow. It will be up for second reading on Friday. That's it.
So I report on Friday.
Yeah.
Okay, thank you.
Terrific. Yes, sir.
I'd like to just ask a process question. Is there any precedent or is it acceptable or unacceptable on the floor to have the explanation of the dissenting vote on the committee?
You can do it now. You can comment now, and then as part of the report, Senator Gulick could include that in her report. Then if you vote no on the floor, you can say no with explanation and do that.
But
It's your choice.
You can't interrogate the reporter.
You can interrogate reporters, usually not, it's not something that is, done.
If you tell me ahead of time, we can try to provide the information.
I mean, you've been here for all the testimony, so any interrogation would be repetition with what we've done in committee.
Well,
So in some ways, it becomes,
I get that.
it's not a process.
My curiosity is that the chamber might be interested in the counter arguments as opposed to just the reporter's support for it. And again, I'm new to all this.
So it's generally courtesy to your committee that if you vote no in committee, you don't speak up against the bill on the floor. I don't know if there's an official rule, but that's the courtesy that is usually afforded. However, you could ask a colleague, you could say, here were my concerns in committee. Can you ask this on the floor? You could have one of the other senators. And it's also, you know, out of courtesy to the bill reporter, give her a heads up. You might get asked these questions, and you don't have to do that, but it's appreciated when somebody does that. I would say that, yeah, I'm happy to talk to you more about
Having
that.
anyone speak up from the committee doesn't make sense, regardless of whether it's pro or con. That's not true. That's not what happens. If something, and just, we're talking process,